Good evening, all. So, there is an important topic that is abnormal uterine contractions or actions. So, today we will deal regarding abnormal uterine contractions. So, as you know that, in uncoordinated uterine actions that will lead to the atony of uterus, then one of the causes is precipitate labor, then preterm and prolonged labor is a consequences of the abnormal uterine actions. So first we will see the definition of abnormal uterine action. Any deviation of the normal pattern of uterine contractions affecting the course of labor is designated as disordered or abnormal uterine action. Once more, so any deviation of the normal pattern of uterine contraction that will affect the course of labor or time duration of labor is designed as disorder or abnormal uterine action. As we know that the normal polarity, that is upper uterine segment will contract and lower uterine segment will relax and baby will expel. So any deviation in the normal polarity will cause the abnormal uterine actions. So you can see the division, that is normal polarity. As I said before, there is hypertonic dysfunction or excessive contraction. Hypertonic dysfunction, that is uterine inertia common. So in hypertonic dysfunction, there is obstruction not present means it will be precipitate labor. Then obstruction present means tonic uterine contraction and retraction or Bandel's ring. Then hypertonic uterus. So in abnormal polarity, incoordinated uterine action, that is spastic lower segment, colic uterus, asymmetric uterine contraction, constriction ring, generalized tonic contractions and cervical dysplasia. These things will lead to ineffective uterine contractions. So next we will see the etiological factors of abnormal uterine actions. So first one is prevalence in first birth, especially with elderly women. Prolonged pregnancy, if the pregnancy is prolonged, then over distension of the uterus may be because of the tins and fibroids, and some of the emotional factors like anxiety and stress. Then constitutional factors like person is obese, then contracted pelvis and malpresentations. So in all these conditions there is a chance of getting abnormal uterine actions. So once more, prevalence in first birth, especially with elderly women, prolonged pregnancy, over distension of the uterus, emotional factors, constitutional factors, contracted pelvis and malpresentations. So usually the assessment is done by clinical palpation. Then tocodynamometer with the external transducer. Then intrauterine pressure catheter is used to measure intrauterine pressure during contraction. So normal baseline intrauterine pressure is 5 to 15. So above 20 mm Hg is considered as abnormal or increased uterine actions. So this is, we can see the normal and abnormal patterns of the uterine contractions. As we know that before starting any of the uterine contractions, there will be some of the knots will be there, the areas will be there. From there the contractions are starting. So the normal uterine contractions with a single dominant pacemaker focus is on first A. You can see the blue color discoloration. From that area the contraction is starting. There is only one pacemaker is there. Pacemaker means the start where the uterine contraction is starting. So in second picture you can see the uterus with the 3 separate pacemakers firing sequentially. So the contraction will be severe at different places. In picture C you can see the normal uterine contraction. So the contraction is equal in all the places of the uterus. In D you can see the uterine inertia. So the contraction is very less. So in picture E you can see colic uterus. In picture F you can see spastic lower segment firing sequentially. In lower segment there is more contractions. So in picture G you can see asymmetrical contractions. So one side of the uterus is enlarged because of the severe contraction only to that particular area. Then in picture H, cervical dystocia, that is abnormal dilatation of the lower pole of the uterus. So this picture shows some of the normal uterine contractions showing the peak pressure, contraction intervals, pain threshold and rise of the basal tone. So in picture B you can see hypertonic contractions with prolonged duration. Picture C shows hypertonic contraction with increased frequency. Both B and C showing changes in the fetal heart rate or decelerations. So in picture A there is intrauterine pressure kilopascal or mm of Hg. You can see the active pressure area, that is dark blue color area. The basal pressure you can see, and pain threshold is high. Then you can see the proper contraction interval in between two abnormal contractions. So in this picture, this is called a constriction ring or Bandel's ring. So there will be a sphincter formation, that is in cephalic presentation around the neck of the baby. Because of that, baby cannot come down. So in this picture, generalized tonic contractions of the uterus you can see. So in this condition, we cannot palpate the baby's body parts properly. So what are the nursing management you can give for the abnormal uterine contractions? Risk for perineal trauma related to rapid labor progression. Risk for maternal hemorrhage related to rapid delivery. Risk for neonatal respiratory distress related to rapid delivery. Acute pain related to intense and rapid contractions. Risk for maternal emotional trauma related to rapid and unplanned labor. So in this picture you can see normal labor. Picture A shows normal labor. So picture B shows late obstruction. Note the circumferential dilatation and progressive stretching of the lower uterine segment with the corresponding thickening of the upper segment and rise in the level of the retraction ring following the obstruction. So there is a difference between the constriction ring and retraction ring. So first I will read regarding the constriction ring. It is a manifestation of localized incoordinate uterine contraction. Undue irritability of the uterus will be there, usually at the junction of upper and lower segment, but may occur in other places also. Retraction ring. It is an end result of tonic uterine contraction and retraction following obstructed labor. It is always situated at the junction of upper and lower segment. So we can see in constriction ring, usually upper segment contracts and retracts with relaxation. In between, lower segment remains thick and looser. Polarity is abnormal, almost unaffected unless the labor is prolonged. Uterus feels normal and not tender. Fetal parts are easily felt. Ring is not felt. Round ligament is not felt. FHS is usually present. Lower segment is not pressed by the presenting part. Ring is felt usually above the head. Features of obstructed labor are absent. So in retraction ring, it is always situated at the junction of upper and lower segment. Upper segment is tonically contracted with no relaxation. The wall becomes thicker. Lower segment becomes distended and thinned out. Polarity is normal. Features of maternal exhaustion sepsis appear early. Uterus is tense and tender, not easily felt. Ring is felt as a groove placed obliquely. Round ligaments are taut and tender, usually absent. Lower segment is very much pressed by the forcible driven presenting part. Ring cannot be felt vaginally. Features are present. So this is regarding the difference between the constriction ring and retraction ring. So we will see the management of dysfunctional labor. So non-progress of labor, that is maybe because of the arrest in cervical dilatation or maybe arrest in descent of the fetal head. So we will do reassessment. Then for mother uterine contractions we will assess. Pelvic adequacy by clinical pelvimetry we will see. Pelvic tolerance we will assess. Evidence of any infection or dehydration we will assess. Then for fetus, FHR pattern we will see, estimated fetal weight we will see, then fetal presentation position and station we will see, then a liquor color we will see. Then to correct dehydration, sepsis, we will start IV ringer solution and antibiotics. So evidence of CPD, fetal distress and big baby is there, we will do cesarean delivery. And if pelvis is adequate, average weight of the fetus with engaged head but inadequate uterine contraction is there, then for that we will start oxytocin. Then amniotomy we will do if not done before. Then pain relief measures like epidural analgesia when cervical dilatation is greater than 3 cm. Then fetal monitoring through electronic fetal monitoring is preferred. Then progress is satisfactory means vaginal delivery we will conduct. If there is no progress of labor, first stage cesarean section we will do. If second stage cesarean section, operative vaginal delivery by forceps or vendos we will do. So this is regarding the management of dysfunctional labor. Hope you understood. So next we will see the preventive measures of dystocia due to abnormal uterine actions. So as you know that there is quality antenatal care, emotional support to be parturient and close monitoring of labor can reduce the abnormal uterine action. And also induction of labor should be judicious, especially when the cervix is unfavorable. Amniotomy in the latent phase or as a routine procedure is to be avoided. During the course of labor, the woman should be given adequate moral support, rest and analgesics. Her hydration should be maintained. Management of labor should be plotted parthographically so that any deviation from the normal is detected and managed very early. So signs and symptoms of the uterine atony. The main sign of uterine atony is postpartum hemorrhage or excessive blood loss after delivery. This can cause a drop in the arterial blood pressure and consequently increase the heart rate. Individuals may also experience pain, especially in the lower back. So uterine atony means the uterus is not at all contracting. It is keep on relaxing. So atonic uterus. What are the nursing diagnoses in atonic uterus? Inadequate uterine contraction is there. So there is a risk of excessive bleeding in postpartum period. Then ineffective tissue perfusion is there. Why? Because there is reduced blood flow to the uterine tissue due to poor contraction can lead to compromised tissue perfusion. Risk for infection is there, that is because of the prolonged retention of placental fragments and blood clots due to uterine atony increases the risk of uterine infections. So next we will see preterm labor. So what do you mean by preterm labor? Preterm labor is defined as ones where the labor starts before the 37th completed week, that is less than 259 days, counting from the first day of the last menstrual period. The lower limit of gestation is not uniformly defined, whereas in developed countries it has been brought down to 20 weeks. In developing countries it is 28 weeks. So preterm birth is the significant cause of perinatal morbidity and mortality. So once again I will tell you. So what do you mean by preterm labor? So preterm labor is defined as ones where the labor starts before the 37 completed weeks. So what are the high risk factors? History, that is if there is an increased incidence of preterm labor in cases such as previous history of induced or spontaneous abortions or preterm deliveries, pregnancy following assisted reproductive techniques, and asymptomatic bacteriuria or recurrent urinary tract infections, smoking habits, low socioeconomic and nutritional status, and maternal stress. So what are the etiopathogenesis of preterm labor? So because of the activation of fetal HPA axis, that is chorion, amnion and residua, there is increased CRH and increased cortisol, choriodecidual bacterial colonization, increased TNF, increased IL-168, pathological uterine enlargement will be there because of polyhydramnios and multiple pregnancies, increased mechanical stretch, increased gap junction, increased PG synthetase. So because of that, chorion, amnion and decidua increased PGE to F2, increased TXA to leukotrienes, decreased PG dehydrogenase, increased proteases, increased collagenase, increased leukocyte elastase. Because of that, increased myometrial contractions will be there, increased cervical ripening will be there, increased cervical insufficiency. So preterm labor and delivery is a consequence of all this ethiogenesis of preterm labor. So how we can maintain adequate hydration is maintained. Prophylactic antibiotics is not routinely given. It is recommended when function is evident or culture report suggests. Then prophylactic cervical encirclage for women with prior preterm birth and short cervix in the present pregnancy may be beneficial. Tocolytic agents, various drugs that is nifedipine, atosiban, progesterone, micronized have been used to inhibit the uterine contractions. The tocolytic agents can be used as a short term, that is 1 to 3 days, or long term therapy. Tocolytics should preferably be avoided as there is no clear benefits. Dose schedule of MgSO4 and monitoring are same as used for seizure prophylaxis of preeclampsia, that is 4 gram IV over 3 to 5 minutes. Then we will see the management in first stage and second stage. So in first stage, patient is put to bed to prevent early rupture of the membrane, to ensure adequate fetal oxygenation by giving oxygen to the mother by mask. Epidural analgesia is of choice. Labor should be carefully monitored, preferably with continuous electronic fetal monitoring. Caesarean delivery is done for obstetrical reasons, only hypertension, abruption or malpresentation. NICU is a synchrone for good outcome. So in second stage, the birth should be gentle and slow to avoid rapid compression and decompression of the head. Episiotomy may be done to minimize the head compression if there is perineal resistance. Tendency to delay is curtailed by low forceps. As such, routine forceps is not indicated. The cord is to be clamped immediately at birth to prevent hypervolemia and hyperbilirubinemia. To shift the baby to neonatal intensive care unit under the care of a neonatologist. So next we will see prolonged labor in next video. Hope you understood abnormal uterine contractions and preterm labor. So thank you for watching. Please share to your friends also. Thank you.